Microfinancing for advancing sustainable development through micro business is the next topic by Maziar Zarrehparvar, Oxford researcher in sustainability and chair of Sustainable Finance Conference, USA. Mazi is principal investigator on two ESG research projects at the Global Center of Healthcare and Urbanization at Kellogg College. He's a regular speaker at the Oxford Masters in Sustainable Urban Development Program, where he advises students on thesis selection and planning, and is the organizer for the annual Sustainable Finance Conference at Kellogg College. Mazi is also an investor and an entrepreneur, with projects ranging from livable, low-carbon urban development to deep tech life science spin-offs from UCLA, UCI, Bath, and the University of Edinburgh. We welcome Mr. Mazi on this. Thank you.
Thank you very much, Sagarika. It's a pleasure to be here, and it's really quite an honor to follow Dr. Gopal. The last presentation was very impressive and exciting to see the kinds of work that are being done to try to bring healthcare to India. I will touch on that today actually as a good example of microfinancing. So first, a little bit about myself. As you mentioned, I carry out research at Oxford University, and every year I host a sustainable finance conference there. And it's been very exciting to see the way the financial community has started to embrace sustainability. However, most of the attendees at my conferences are major institutional investors, and I don't see much movement yet in the direction of major institutional participation in microfinance. As we all know, capital is the key to upward mobility. Most people spend much of their life as employees and are not able to save enough money to build their own business. And building a business is not what everybody is meant to do. So we have to be very clear that only some people actually want to be entrepreneurs. The classic image of a micro lending operation looks something like this. There's a very community-based lender, and money is lent out and tracked, and interest is collected, oftentimes at very, very high interest rates. Of course, we all know that oftentimes these loans are not used to start businesses, but these loans that are made in rural communities in particular sometimes are used for income smoothing or to pay for major events. Although quite important, paying for your children's marriage is not social entrepreneurship. Microfinance is not the same thing as microlending. Microfinance is supposed to be used to actually build a business, to start a company, or to create an opportunity for developing assets that will produce income. Microfinance is supposed to empower, and it goes beyond just a loan. It can include insurance products, it can include savings, and basically it's about financializing people who have not traditionally had access to financial resources. But without capacity building, capital in the hands of somebody who lacks the know-how, the expertise, or the support, or the education to become successful, that capital is not necessarily going to be used in the best way. So one of the challenges with microfinancing is what else needs to be done to leverage this capital in order to create successful outcomes for a prospective entrepreneur. I'm really proud of a dear friend of mine, Dr. Satadal Saha, who has developed a scheme in West Bengal, starting out of Calcutta. And I want to describe this scheme to you as a case study for effective microfinance, because it's bundled within empowerment and training program, not as a standalone microfinance event, but as a comprehensive program. Dr. Saha started his career by training as a surgeon in London, and after several years of practicing medicine in London, came back to his native Calcutta. And he realized he could not really improve the healthcare for people in rural communities sitting in Calcutta. And he also saw that there were many young women in rural communities who were graduating from middle school, getting married, and not having opportunities to improve themselves or create economic means. So he worked with Johns Hopkins to develop a tablet-based software that could be used as a frontline healthcare intake system. So as you see in the image there, there's a young woman with a tablet. That tablet has an expert software. That expert software was developed between Dr. Saha and Johns Hopkins University in the US. It's a questionnaire. So if the patient comes in a village setting and has a complaint, that questionnaire allows the frontline healthcare worker to assess that patient. That information is then sent to Calcutta and to physicians. Those physicians are then able to assess the patient's situation and make a recommendation for action. So we call this process a digital clinic. So women normally from disenfranchised backgrounds who have achieved middle school certificates and who want to be self-employed, and that's a critical factor, is that they should want to be self-employed and they should want to be entrepreneurs, are given training to certify them as community healthcare workers. This training certificate is useful for them, not only working as frontline healthcare workers with the tablet, but they can also go work in a hospital or in a medical setting. The government subsidizes this training. Of course, 50% of the training eventually has to be paid back, but initially the upfront costs are all subsidized by the government. In addition to this training and certification process, seed funding is provided, and a group of these graduates from the 6-month training program form a partnership firm. This cluster of individuals will then service a certain geography, a certain population size, or what's called catchment area. They will share resources, for example, potentially a PC, a central location from which to transmit data back to Calcutta, or a kiosk, a healthcare kiosk, depending on the resources that they have available. But Dr. Saha's organization, JSV, provides seed funding to start their business. In addition to the seed funding, they're provided with the smart software, the tablet, and access to doctors in Calcutta. They also receive supply chain support for things like medicine and disposables. That could be gloves or thermometers, whatever they might need in the field. And most importantly, they receive training on how to be small business administrators. Because of course, being a healthcare worker and collecting money and growing a business are two very different things. And both capacities have to be instilled into these individuals. And then Dr. Saha's team stays with these individuals for multiple years and continually trains them with upskilling and supports them as they grow their business, with the goal that within 4 years of enrolling in the program, again, it's not like 6 months or 5 days or get a loan and then you have a successful business. It's within 4 years of continuous support. The hope is that these individuals will then become independent, self-sustaining business people, both making income for themselves, which of course is one of the social development goals to alleviate poverty, and providing healthcare, which is another one of the important goals to have access to healthcare for all people. So I'm extremely impressed with this model, and I believe that it points the way for the future of microfinance, which is to approach microfinance in a more comprehensive, capacity engaged way. This is my hero, Dr. Saha. That's really all I have to share with you today. Thank you. I finished a little bit early, didn't I?
That's perfect, Dr. Mazi, and really good insights on your case study, something different to learn from. Okay,
Great.
from
Yeah.
India, we're going to move to Africa now.